Thank you, Chairman Haynes. To the members of the committee, good morning. We appreciate the opportunity to be here this morning and to share a little information with you about the hospitals here in Michigan. Before I begin, a couple of introductions. I'm the Senior Vice President for Advocacy at the MHA. Two other people that are important for you to know, sitting behind me, Laura Oppel is our Vice President of Federal Policy and Advocacy, and I think many of you know Chris Mitchell, who is our Director of Governmental Affairs for the Hospital Association, and a face that you see frequently here. Also Bill Wirtz from Public Affairs Associates. Public Affairs Associates works with the MHA, and you may see Bill here in our stead as well. What I want to do is review, as I said earlier, issues related to hospitals. You have a copy of my PowerPoint in your packet, and I assume, Madam Chair, if there are questions along the way, I would be happy to answer them. The Michigan Health and Hospital Association represents all of Michigan's acute care hospitals, and you can see outlined there the mission of the MHA. We do work to advocate on behalf of our communities and try to link providers, hospitals, and patients in the communities together. That has been our mission since our founding nearly 50 years ago. In terms of the membership, outlining here, I think, a slide that is instructive about where the industry is going these days. In 1980, 236 hospitals, and you can see the total number of beds. Nearly every hospital independent, and frankly at that time, virtually every physician working at our hospitals, independent private practitioners. Today we find 144 hospitals, the majority of our membership now in a system of organized care, having at least 2 or more hospitals, 5 out-of-state health systems representing hospitals here in Michigan, and a significant trend toward physician-hospital integration. Today, 20% of the physicians practicing in Michigan are employed by a hospital. Continuing that trend, a slide that provides an overview of, from hospitals reporting to the American Hospital Association, the number of physicians looking for new relationships with hospitals, and you can see outlined on the slide the various aspects of what those partnerships are looking like and how they are being developed today. Again, the key message is hospital-physician integration as we go forward, certainly driven by efforts at national health reform. What we wanted to outline today, a couple of things that we view are mission critical as it relates to Michigan hospitals in today's environment. We want you to understand that healthcare jobs are a very significant portion of what the healthcare industry, hospital industry, brings to Michigan. We are the largest private sector employer, and you can see the numbers identified there. Most of you have at least one hospital in your district and already are well aware of the role that hospital plays in your local community. Over 1 million jobs related to healthcare, with hospital employing 219,000 people. Something that gets lost is the economic impact, $13 billion worth of wages. And while the majority of hospitals in Michigan are tax-exempt nonprofit hospitals, you can see the billions of dollars paid in payroll taxes and, depending on some services in community, local property taxes as well. Another aspect of our mission-critical role is community benefits provided to our local communities in which we are housed and served. $2.6 billion provided in fiscal year 2009 of community benefit. And you can see the categories that are outlined there: health improvement activities in local communities, uncompensated care, and charity care provided to citizens who do not have insurance and who do not have the ability to pay for their care. The tagline at the bottom, Michigan Hospitals, the heart of the community, safety net for the uninsured and underinsured, and increasingly a local resource for health and wellness activities through our communities, partnering with businesses in our communities to help improve the general health of our local populations. Another important aspect of our mission-critical services, patient safety and quality. And I'm happy to report to you that Michigan hospitals, our physician partners, lead the way in the nation in terms of delivering high-quality, cost-effective services. And that's been done through a couple of key initiatives that have been launched in the past several years. The MHA Keystone Center for Patient Safety and Quality started in 2003. It's an effort by hospitals and physicians to determine what are best practices for aspects of care and work to have teams within hospitals and teams across the state to operate in ways that are consistent with those best practices. And one of our initiatives, the Intensive Care Unit Initiative, as you can see, saved significant lives, significant dollars, and bottom line, saved all of us funds that could have been spent on health care, and not to mention the reduction in pain and suffering for patients. MI Hospitals Inform is a website started in 2007 in the effort of increased transparency for patients to understand what it costs for medical care and quality. People who access this site can find information about the top 50 procedures, inpatient and outpatient, at their local hospital, the quality results as judged by independent quality organizations, and can compare hospital to hospital. The latest effort, MHA Patient Safety Organization, is an effort that has created, with the help of the Michigan legislature, an effort where hospital employees, physicians, medical care providers can report on medical errors or near misses in a confidential way, so that information can be tabulated, trended, and taken back out to the field if, for example, there is a drug that is causing problems or a piece of equipment that maybe needs to be operated in a different way. It's an effort that has been very successful in bringing the field together to reduce medical errors. Making care affordable, something you all have heard about and something you will hear more about as we move down the road toward healthcare reform. I'm happy to report that Michigan hospital costs are 3.4% lower than costs nationally, which results in a savings of $538 million related to health care for employees of Michigan business and Michigan taxpayers. The AHRQ is the Association of Healthcare Research and Quality, a national watchdog group for healthcare quality, has reported across all measures in hospital care, Michigan hospitals perform among the best in the country. And as you all know, hospital efficiency and quality improvement are keys to ensuring access and affordable health care. I'm sure that some of you have heard in your constituent meetings that the cost of health care is a concern to the citizens of Michigan. We like to believe, and we believe we have data to support, that Michigan hospitals are contributing to that effort to control costs. A little bit about the Medicaid program, which is obviously very important to the hospital community. Medicaid nationwide now is the largest provider of health insurance, healthcare coverage across the nation. Most of you understand, at least if you've talked with Chris or Laura or me along the way, that 2 million people are covered by Medicare today in this state, and we have an additional 1.35 million people who have no health insurance at all. Combine the two, and upwards of 30% of the state's population is in a program that pays hospitals less than the cost of care, or in the case of the uninsured, nothing unless they qualify for certain other local programs. But for the most part, that is where the hospital uncompensated care comes from. A reminder that every dollar invested in the Medicaid program results in additional $2.48 from the federal government today. The majority of the Medicaid program operates with federal money, upwards of 70%. Not as much general fund as you find in other state departments. A note that I want to highlight, and I think many of you will appreciate, when government does not cover the cost of care, hospitals are left with no choice than to pass that cost on in order to keep the doors open and services available to our citizens. That is many times described as a hidden tax to Michigan citizens, and the Department of Community Health estimates that today that cost of uncompensated care and underinsured coverage through Medicaid represents about $1,000 in additional cost to healthcare premiums for those who have the ability to pay. And a reminder that when services are closed in a community because of Medicaid reimbursement, which again is less than the cost of care, that service goes away not only for those on Medicaid, but for everyone in the community. And a slide that highlights that is on your board now, the impact of Medicaid underfunding as it relates to labor and delivery services. Medicaid now covers 51% of the deliveries in Michigan, and you can see the counties identified on the state map with the X's no longer have labor and delivery services available to them. If you looked at that map in 1980, you would find very few X's on that map. There is a consequence, there are implications for what has been nearly 10 years of no increases to rates of reimbursement for hospitals and physicians, and in fact, significant decreases. That is an issue, by the way, that we are working with other groups here in the state to resolve, to confront, because we are all very concerned about access, timely access to labor and delivery services for the citizens of the state, particularly, as you can see on the map, for citizens in northern lower Michigan and the Upper Peninsula. A quick comment about provider taxes. If you haven't heard about it, you may, as the budget battle begins here next week. The Medicaid program here in this state has been supported over the last 10 years, not with general fund, as I mentioned earlier, but with federal funds, which have been drawn down through the use of provider taxes. Provider taxes on hospitals, nursing homes, HMOs, Michigan's hospitals agreeing to a voluntary tax in order to secure additional federal funding in the face of no available general funds. We now have 4 different programs that bring in an additional $1 billion each year. Some of that goes to the hospital community, some of that goes to the state in retention that is utilized to support the Medicaid program, and frankly, sometimes other aspects of the state budget. The point I want to make here is the bolded one there. This provider tax program and the federal matching funds that come with it now represent 65% of the funding that hospitals receive from the Medicaid program. Saying it another way, we have agreed to tax ourselves in order to create our own funding. I want to underscore, you may hear that because of the provider tax programs, the hospital community is kept whole, that there is no negative impact. That is not true. Certainly there are hospitals in this state that do benefit from the provider tax program, hospitals that have high volumes of Medicaid recipients. But the bottom line is, depending on the program, we have anywhere from 40 to 70 hospitals that do not benefit from the provider tax programs. We need the money. The provider tax programs have helped us all survive. But you will hear from members of the hospital community who've received no benefit, and as long as there is no general fund available to improve Medicaid rates, that is a very difficult circumstance that we all deal with and will continue. Winding down, another thing that's very important to the hospital community, and many of you have heard about this as well, the Certificate of Need program. We have a Certificate of Need program in this state which tries to help balance cost, quality, and access to services. The elimination of the CON program, from our perspective, would lead to cherry picking of profitable services by other groups, putting more pressure on your local community hospital, which continues to try to provide a full range of services. I want to be very clear that the Michigan Health and Hospital Association and our members support a strong Certificate of Need program. Graduate medical education, something that some of you have talked with us about and understand the importance of that. Graduate medical education, and the state does fund through the Medicaid program. Graduate medical education pays for physicians in residencies, and those physicians work very hard in our local communities providing care to patients. Their pay, as you can see identified on the slide, not much for the services that they deliver. As you can see on the slide, we believe that GME is a great investment in high-tech, high-wage jobs, and those who train in Michigan tend to stay in Michigan. Many of you know that we are moving toward, in 2015, an estimated shortage of 6,000 physicians in this state to care for our citizens. Graduate medical education is a very important part of sustaining that physician workforce. Little commercial here, and it's in your packet. If you're interested in graduate medical education, we have a day coming next week. We invite you to attend and learn more about that. Last comment, national health reform. We could spend the next 3 days talking about national health reform, the implications on the hospital community, the physician community, and citizens of this state. We don't have that time. I have included in your packet a timeline for national reform which lays out timelines for implementation issues, for hospitals, for physicians, for patients, for the insurance industry. I think if you're interested, you will find that to be a helpful document. This slide highlights, though, very briefly where we're headed with national reform, and from a provider perspective, there will be increasing pressure to provide more integrated care, hospitals and physicians and other medical providers working more closely, more at-risk payments, and more accountability. We understand that, we accept that, and I think, as you heard me mentioning earlier, we think Michigan's hospitals have moved in this direction voluntarily and really are ahead of the curve on meeting some of these challenges. Madam Chair, with that, again, we appreciate the opportunity to comment and would welcome any questions the committee might have.
Thank you, David. Before we begin with questions, I would like to introduce Senator Marlowe, who is the chair of the Senate Health Policy.
Good morning.
Good morning, and thank you for joining us, Jim. David, I have one quick question. Do you believe that the increase of Medicaid eligibles due to the national health care reform will affect the number of counties that currently lack services?
Under national health reform in 2014, we expect approximately 400,000 people to be added to the Medicaid rolls. That certainly creates a challenge for all of us. The initial part of that, the first few years, will be 100% federal government funding. We think that that will go a long way toward reducing the uncompensated care that hospitals have today from those 1.35 million people who do not have coverage. That's a long answer to essentially, yes, I think that will be a benefit, certainly to the residents and to the providers of this state in terms of having additional dollars to provide coverage for care.
Thank you. Are there any other questions from members? Representative Colton.
Thank you, Madam Chair. I just have a couple of questions. One is very quick. When you said that Medicaid or unreimbursed visits cost us $1,000, did you mean $1,000 per month or $1,000 per year?
$1,000 per year. And again, that was a statistic that was offered by Mr. Steve Fitton during his testimony to the House Appropriations Subcommittee on the Department of Community Health budget.
Thank you. Madam Chair, can I follow up with one more question?
Yes.
Thank you, Madam Chair. Thank you for your presentation. It was very good. It was very eye-opening. The obstetrics portion, all the counties that do not have that. I had always thought the loss of obstetric services was due to liability, but you say it's due to unreimbursed visits.
There is no question that liability costs play a role there as well. Liability costs have driven the majority of obstetrical providers in this state into partnerships with hospitals because of the difficulty in paying those costs, it certainly plays a role. But I would highlight again, 51% of the births in this state are paid for by Medicaid. Medicaid, depending on the hospital, will pay anywhere from 55 to 80% of cost. Hospitals are increasingly unable to sustain that cost and keep the doors open for other services. So it certainly plays a role.
Representative Siegel?
Thank you, Madam Chair. My question is more with the number of jobs that the healthcare industry provides and the work that our hospitals do in our community. Is there anything the legislature should be looking at to making the regulatory environment better for our hospitals?
Good question, Representative Siegel. We are in the process of looking at regulatory requirements that we don't believe add value to the citizens of Michigan. They don't do anything to improve quality or reduce cost. That is something we would be prepared to come back and share with you. But off the top of my head, at this point, no, I'm not prepared to comment on that.
Representative Yonker?
Thank you, Madam Chair. You referred to your industry, the hospital industry, allowing themselves to be taxed.
Mm-hmm.
How is that tax applied? Is it like a business tax, or is it a line item tax that the customer gets when they pay their bill?
No, it is a tax administered through the Department of Community Health that is based on a formula that has been worked out and negotiated between hospitals and the department. It is guided by some federal regulations about how much tax can be applied and how that tax has to be collected and distributed. But no, it's not something that ends up on a hospital or a patient bill.
But it is included in the overhead costs of running the hospital, correct?
It would be.
It's recovered through the balance sheet.
It would be, yes.
All right, so we're already then starting to realize an increase in health care due to higher taxes. Is that fair to say?
I guess what I would say is the result of that tax is additional federal money, which helps control the cost at a state level. Now, one could argue that higher tax results in an implication at a federal level in terms of taxes. But I would say no, at a state level, that provider tax does not result in increased costs to state citizens.
Thank you. Representative Yonker? Oh, I'm sorry, Shirky.
Thank you for the compliment, Madam Chair. Dave, this is a follow-up actually on Representative Siegel's question. It was more specific in nature, but on the gap that's created for reimbursement for obstetrics primarily, does the MHA have any research or position on that in terms of how much of that gap is really due to liability cost element?
I don't know that offhand, Representative. That is something we could work to find for you.
I think it'd be helpful, because that is something that we can specifically look at least, and analyze. You may have follow up with a second question, Madam Chair.
Yes, thank you.
I agree with you that in the short term at least, healthcare reform could end up in bridging some of the gap on uninsured costs. That's assuming, of course, that we can continue to borrow money from China. But once that runs out and the federal government puts bridging that gap, in year 4 and beyond, aren't we headed for a train wreck?
I think, I don't know whether we're headed for a train wreck or not, but Representative, I would agree with you that the challenges of how this country and this state will manage the issue of health care for our citizens is one that is open for debate. We've debated it intensively over the last couple of years, and I think we all know that debate will go forward. What I can tell you from the hospital perspective is, while we are sensitive, we are all taxpayers as well, while we are sensitive to that, the bottom line is we have a lot of people in this state and in this country that don't have coverage. And the way we deal with that today is shift that cost around. And that's a challenge that has to be confronted.
And Madam Chair, Dave, that wasn't a baited question, because I tend to agree with you in that, and that we don't want to become complacent, because we may have this short-term period where it looks like it's being covered over, you know, in year 4 and beyond, and we need to plan now for that. So that's the only, I'm trying to reinforce, frankly, what you're trying to help us understand.
The only follow-up comment I would have to that is the legislature, the administration, the administrations over the past 10 years or so have been very sensitive to the challenges that we face in healthcare, and we have found the legislature to be relatively understanding, and previous administrations, and frankly, I think the Snyder administration, very sensitive to this problem as well. And we look forward to working with the legislature and the governor's office to confront these challenges.
Thank you. Excuse me. Representative Hovey Wright?
My question was already asked.
Thank you. Representative Hooker?
Yes, Dave, do you have any kind of numbers on the uncompensated care and even the charity care and possibly the health improvement free clinics? How many of the numbers that we have and the dollars that are spent are by undocumented citizens or people that are in Michigan?
I do not have that number, Representative. I know that is something that the Department of Community Health has been asked by the legislature to monitor in the past. I will work to see if I can get that number for you.
Thank you.
Thank you. We'll have one more question. Representative Womack.
Thank you, Madam Chair. I'm going to pass.
Thank you. Seeing no more questions, thank you, David, very much. I would now like to ask Megan Swain of Michigan Association of Local Public Health to come forward.